AMP2.TV presents You and Your Doctor, teaching you to live a longer and healthier life. Proudly sponsored by All County Healthcare, where people are the heart of our business. All County Healthcare is a Medicare certified agency where one call will service all your home care health needs. For more information, call 954-717-7027 or visit our website, allcountyhealthcare.com. Now, let's get informed to living a longer and healthier life. Here is your host for today's show.
Good evening. Happy Thursday, everyone. Welcome to You and Your Doctor, sponsored by All County Healthcare. All County Healthcare is a Medicare certified home health agency working in Dade, Broward, and Palm Beach County. Give them a call, 954-717-7027 or info@allcountyhealthcare.com. I am your host, Dawn Grauber, and I have a wonderful doctor to share with you tonight. We have Dr. Sue Cohn with us. Dr. Cohn is a board-certified pain medicine specialist and anesthesiologist, born and raised in Colorado. She moved to New York to attend NYU, where she graduated Magna Cum Laude and remained in New York to earn her medical degree from New York University School of Medicine. Dr. Cohn completed her internship at University of California, Los Angeles, UCLA, then returned to New York for a 3-year residency in anesthesiology at St. Vincent's Medical Center and Mount Sinai Medical Center. She went on to complete a fellowship in interventional pain management at the University of Miami Jackson Memorial Hospital. Dr. Cohn specializes in a multimodal and interventional treatment of chronic pain. She focuses on conditions such as back pain, complex regional pain syndrome, CRPS, trigeminal neuralgia, and nerve pain, offering compassionate, comprehensive care to improve her patients' quality of life. Dr. Cohn can be found at Florida Spine Associates, info@floridaspineassociates.com, or give them a call at 561-269-8646. Welcome, Dr. Cohn.
Thank you. I appreciate it.
It is such a pleasure to have you joining us. Since I have been hosting, we have not had an anesthesiologist join us.
Oh, that's great.
So this is really a treat for everyone to understand more about what you do. So explain a little bit, what is anesthesiology? What is pain management? What does that look like?
So pain management is what I specialize in, and a lot of times most of the physicians that go into pain management come from anesthesia. They can come from other backgrounds like PM&R or neurology, but usually anesthesia is like the big feeder, and it's mostly based on spine issues. So for anesthesia, we do labor and delivery, and that's what we train in for part of our focus. And so we do a lot of epidurals, spinals for pain control during surgeries and things like that. And I think that's when the offshoot happened into pain. So pain management, usually kind of the bread and butter of it is spine issues like disc herniations in the neck or the back that you might want to manage without surgery. And so that's kind of how it kind of came from anesthesia into pain.
You focus mostly on back pain and nerve pain.
Yes.
And you're at an ortho, you're at a spine center.
Correct.
But you also work with nerve pain.
Yeah.
What's the difference between pain comes from nerves, right? It's our nervous system causing the pain in our body.
Yeah.
Even though it could be spine or you break a bone, it's not the bone that's hurting, it's the nerves that are sending the pain signals.
Yeah, that's an interesting question. So like pain is how you perceive noxious stimuli. So maybe you break a bone and the nerves are conducting that signal to your brain. And there's so many ways to treat that. You can treat the bone, you can treat the problem that's causing the pain, which is what we really want to do. So if something's wrong, you want to fix it. But then sometimes things go awry and the nerves are saying something's painful that you can't correct maybe. And then at that point, pain management goes to how do we make those nerves not send those signals to the brain. So there's so many different ways to approach it. But yeah, pain is very interesting in that it's not just, you broke something and then you feel it. There are a lot of in-between steps that can be, treated that may not be like, hey, I broke my bone, it's going to be what it is, maybe, or arthritis, it's not curable, right? Like you can't fix your arthritis unless you do a joint replacement or something like that. But then maybe you can manage the signal that's coming from that area and stop that from getting to the brain and giving you a quality of life.
Yeah, so before we go on the tangent of different modalities, different pain sources, what made you so interested in going into pain management?
I did not know I was going to go into pain management. So Life is funny. I think you just kind of get put into places in your life. I thought I was going to be an ER doctor. And then when my mom passed away and I changed from UCLA to like New York, the program that was available was anesthesia. I took it and it ended up great because I love what I do. And I think things happen for a reason in that way. But that wasn't my initial plan. I ended up here, but I love it.
What do you like about it?
I think, so I went into anesthesia, and if you do straight anesthesia, patients are asleep most of the time. I mean, you do talk to them before and after, and you get them through a difficult period. But after they're, awake and go home, you don't see them again. Somehow, I ended up going into pain off that offshoot, and I'm a very people-y person, and I like seeing patients over and over again. So I don't know. I feel like it was fate. It just kind of worked out the way it was supposed to work out.
And how long have you been in Florida?
Good. Oh gosh, dates and times are hard. But I think it's more than 14 years. 14 years.
And you're mostly ortho based.
Yeah, I mean, ortho's like a very painful. It's very spine, arthritis. That's that's like the very the majority of patients that end up having pain is ortho conditions. So it's an easy starting point. But there's a lot of other things that we can offshoot into.
So if we look at ortho, chronic pain versus acute pain, right? You slip, you fall, you herniate a disc. Things that you can do, that's considered acute, right? Because it's a new injury.
Right.
How does that get treated differently than someone who comes in with arthritis, for example?
Oh, wait, that's a good question too. Acute pain, hey, you broke something and within 3 to 5 days as it's healing, it's gonna go away. Or you cut yourself and in 7 days it's going to heal. And during that period, you can just take medications or just kind of block the signals to your brain until you feel better. But chronic pain is different in that it's not going to go away, like neuropathy type of things where we can't fix it. You're going to have it forever. So then in that case, just bandaging it with a pain medication may not be the best option because the pain medication lasts 8 hours or something like that. And then when it wears off, you're back where you started and now you're in this loop. So that's where different treatments come in.
So is there a treatment for neuropathy?
There are. There's the nerve medications that I'm sure a lot of patients know about, like gabapentin and Lyrica. But they take time to build in your system. Not only that, but it does have, your brain's a big nerve. So if you're kind of dampening nerve sensations, sometimes people get sleepy and tired. So it's a great drug. It has very few side effects other than being sleepy. It doesn't not so toxic on the organs or anything like that. And then there are other more invasive things where they can put spinal cord stimulators into the spine to distract you from the signals that are coming from the feet. So it can go from medications to injections and implantable devices.
And do you do all of that?
Yeah, we do that. We do all of it.
All right, and it says a multimodal approach to pain. What does that mean?
So we don't want to just treat pain with one thing. So we don't just want to give you a pill to treat your pain. Or just do physical therapy for your pain. Most of the time it works better if you're doing all of those things. Like you're making sure you're healthy, like you're strong, and you're going through physical therapy and you got good posture, and you have medications that might help. And on top of that, you treat the underlying condition. So you want to attack it from more than one source. You don't want to just rely on one thing and just kind of repeat that over and over and over again.
And before people come for interventional pain treatment, let's talk about what interventional means.
Yeah. So interventional. So there's 3 ways to treat things, or maybe 4, like physical therapy, right? And then there's medication management. And then interventional comes it's somewhere between medication and surgery. So we're doing a procedure, but it's not as invasive as a surgery, and hoping that that's enough that to get you the quality of life that you want. And then beyond that, it would be surgical procedures.
And ultimately, you want your patient to have a good quality of life.
I mean, with chronic pain, our goal isn't to fix the thing. So, I mean, you can, let's say arthritis, you can do a knee replacement surgery or a hip replacement surgery. But there are a lot of patients that might not be in the condition to go through something like that. So now we're just managing it. And so when you're managing chronic pain, you just want to give them a quality of life. So if we can give you a shot 2 or 3 times a year and you can still do the things you want to do, then that's manageable. Don't go through a more invasive surgery. However, if you can't manage with those kind of minimally invasive procedures, then we talk about the risks and benefits of something more invasive.
And if we're talking herniated back, a disc,
Yeah.
there's epidurals, there's facet injections, right? You've got PRP, there's a lot of different things.
Yeah.
Do you use all of those?
Yeah. So with back pain, people think all back pain's the same, like, oh, my friend got an RFA and that worked for him, and I got an epidural and that didn't work. But it's so different. There's so many reasons to have back pain, and each person's very specific. So a disc herniation, let's say, if you have a bulging disc and it's causing sciatica, that's one set of things that you can do, which is epidurals or surgery. Or if it's just back pain because you have arthritis, that's a different set of things like facet injections and RFAs. So it's all dependent on what your problem is, and it's hard to like mix and match with when patients go, oh, my friend did this thing and it helped him, but that's not your problem. You have a different problem.
You have to look. And you're looking at reducing the inflammation, because a bulging disc doesn't necessarily mean with injections that you're fixing the disc.
Right.
You're actually just mitigating the pain.
Right. So we say that like it's a cartilaginous disc and it's bulging out, and if we can get it not to touch anything, it's just hanging out, it might not bother people. So people can have severe spinal stenosis. Like I've had patients that come in and there's very little space there, and you go, how have you been? And they come in because they had 1 week of pain, and you go, this is incredible. Like there's no space, but they've adjusted to it and they've never had pain. So it's not always about what you see on the picture. It's about kind of how they adjust to it. So if someone has a bulging disc and it's pinching something, then we want to bring the swelling down so it stops touching the thing, and they might be good for a while. I mean, it's not going to fix it, but they might be doing well for a year or more or months. It's hard to say.
And it has to be patient by patient, because there's got to be cases where the patient presents with significant pain, but on scan, there's nothing significant to look at.
Right, exactly. So someone might have severe stenosis and be walking, you go, oh my gosh, this guy has no space and they're doing great, and they just have a little pain in their back, versus someone who like acutely herniated their disc and it doesn't look horrible, but it's touching their nerve, and so they're having a lot of pain. So everyone's different.
That's why they have to come see you.
Yeah.
All right, we're going to take a quick commercial break. More with Dr. Cohn on the other side. We'll be right back.
All County Healthcare has exciting news for any and all patients with COPD or other respiratory ailments. Listen to what renowned pulmonologist Dr. Keith Robinson has to say.
Hello, I'm Dr. Keith Robinson, board-certified pulmonologist, medical director at Fusion Health Pulmonary Rehabilitation, and a board member with the American Lung Association of South Florida. We have exciting news for patients with COPD. We now offer IPV therapy at home, which has been demonstrated to improve airway clearance, decrease hospitalization, and improve quality of life of patients with COPD. Please call All County Healthcare for more information about this FDA-approved therapy.
For further information, call All County Healthcare now at 954-717-7027. That is 954-717-7027, or visit our website at allcountyhealthcare.com. You can also find us on Facebook, YouTube, Twitter, Instagram, and LinkedIn. Remember, All County Healthcare always puts the patient's needs first. You are listening to You and Your Doctor, Living Longer and Healthier, an informative show that helps you find answers to questions you always wanted to ask, but did not have that somebody that could make a difference in your life. Call into the show if you have a question at 888-565-1470, and we will put you on the air to inform all our listeners. Now, back to our show.
And welcome back to All County Healthcare. You and your doctor, sponsored by All County Healthcare. They are a Medicare certified home health agency operating in Dade, Broward, and Palm Beach County. For more information, give them a call at 954-717-7027 or info@allcountyhealthcare.com. Tonight we are here with Dr. Sue Cohn of Florida Spine Associates. You can contact the office at 561-269-8646 or info@floridaspineassociates.com. It's always nice when we go to commercial break because we get to catch up on things that are happening in medicine as well.
Yeah.
So interesting, we just told me about Albert Einstein.
School of Medicine is now free if you enroll, or all those who are enrolled at Albert Einstein School of Medicine, tuition's free, and NYU School of Medicine, tuition's free.
That's amazing.
Which takes the burden off of the physicians. There's a lot of doctors that come out with a lot of student loan debt, and so a lot of doctors kind of funnel into the high earning potential specialties, right? Instead of going into primary care or certain specialties that are very needed. So that I think the purpose of that was to expand so that doctors don't go into a specialty just to make ends meet. They're going into something that they actually want to do.
And also because I think we're losing good quality physicians because they're coming out with such significant student loan debt.
Yes.
And then you think, how am I ever going to pay it back and make a living, especially now with medicine the way it's changed?
And that's why I think they did that, so that hopefully not everyone goes into plastic surgery just to make ends meet, or something that's, cash pay or something like that. Like they're going into medicine to go into medicine because they want to do it.
To help the patient.
Yeah.
Because ultimately, I think as physicians, you go into medicine to help people.
Yes, I think most people do. And then, it's unfortunate, not that it's unfortunate, but medicine isn't the lucrative career that people think that it is. It's not, people think that people go into it for a certain lifestyle, but that's not how it ends up for a lot of a lot of physicians. And they do come out because they have to go to 4 years of college, 4 years of medical school, which is all tuition. They have a lot of student loan burden. Then they have families. And so it puts a lot of stress on physicians. They burn out quickly, and we don't want that. We want them to be there happy and doing what they want to do because they're there because they want to be there.
And ultimately, you're taking care of lives all the time.
Yeah.
And the stress of seeing people in pain and what their families are going through. It has to affect you, right? And so it's nice you take the time to be with your patients.
Yeah, you just don't want them to burn out. I mean, people go into it like OBGYN, let's say. They end up taking call every 3 days, right, to make sure that they're on call for their babies being born. They're born at any time of the day. And how long can you do that, for 20 years, 30 years?
So you burn out.
Yeah, and, you see a lot of difficult things, too. If something goes wrong with the baby, you feel guilt. It's not an easy profession.
Yeah.
And most people are not going into it for, any other reason than they love it. Yeah.
You love it.
Yeah, I'm thankful for what I do because I absolutely love it.
You can tell that you love it.
Yeah.
All right, let me ask you about CRPS, Complex Regional Pain Syndrome.
Yeah.
What is that?
Okay, that's a tough one. So it's a condition that can happen whether you've hurt yourself or not. So the kind of CRPS that we mostly see is someone's had surgery or they had an injury, and for some reason their nervous system doesn't react the way it's supposed to. And so what happens is they get this sensitivity and this pain in the area that they've injured, and it goes way beyond healing. So you might have broken your foot, but now you still have a really big red swollen foot that's painful. The bones have healed, but you don't understand why it's still hurting and you can't walk on it and it's swollen. So that's CRPS. There are CRPS that symptoms that can happen even without an injury. So you did nothing and suddenly you have this weird swollen red hand and you don't know why that's the case. And it's just a nerve injury that is hard to understand. There are criteria that put you in a particular, category. However, a lot of times when people don't understand what's going on, they just call it CRPS.
Okay.
So you might not actually have it, but they're like, we did surgery and we fixed your bone and you're still in pain. We don't understand. And they'll call it CRPS, but it's not, it's kind of a difficult thing to define sometimes.
So it's almost like, I guess if you have an amputation, you still have the phantom pain with that?
That's not CRPS.
That's really
but yes,
phantom
it's
pain.
phantom pain. Yeah, that's a whole nother criteria where you don't have that limb anymore, but you feel it. But so it's similar in the fact that these nerves are firing and we don't understand, why.
What are some of the treatments for that?
Same thing, kind of with neuropathy, nerve medications, distracting you from the pain. They're blocks, so we think that a lot of the pain comes from the sympathetic nervous system, your fight or flight system. So we can kind of block that system and see if almost like resetting a computer.
Okay.
You can block it and see if when it comes back online that it works better. So they're, injections, medications, and then like distracting you from the pain.
And when we're looking at the difference between nerve blocks or epidurals, different spinal procedures for inflammation, what are some of the tests? Someone comes to you and says, Dr. Cohen, my back hurts.
Yeah.
Step one, what are you looking at? Or do they go ortho first before they come to you?
Oh, that's a good question. I think it doesn't matter whether you go to like an orthopedic or a pain management person for back pain. They're going to probably do the same steps, which is a lot of times the most common thing is like a musculoskeletal injury. Like you pulled a weed, you pulled your back, you're gonna a sprain, and you're gonna get better with an anti-inflammatory ice. The usual things. Right. So you do that first, no matter what, and you get an X-ray if you think something's broken, or you think it's a bony abnormality. But then if you do all those normal things, ice, heat, rest, and it's still persisting, then the next thing would be like a bigger scan, like an MRI would be the best thing. If you have a pacemaker, sometimes you might not be able to get one, so we'll like settle for a CT, and that'll show you discs, bones, kind of soft tissues, all kinds of things. If you're having like nerve symptoms and we can't tell, hey, is this neuropathy or is this a disc issue, and we're kind of concerned, we don't know, then we might order like an EMG or nerve conduction study, and that kind of gives us a little more information as to where it's coming from. So those are the main tests.
So you're looking at gathering information before you go in and do any type of procedure.
Yeah, because I know a lot of patients go, we have an MRI, you should know what's wrong. It would be great if you could just like scan the body and someone goes, that's the problem. But it's more kind of like police work. It's you have a problem, like a crime to solve, and then you have little clues that you pick up. So like the MRI tells you this, and the person's symptoms, what they feel, tell you this. So it's not always clear cut. You kind of have to put all the pieces together to get to the answer sometimes.
And it takes time. Trigeminal neuralgia, they say, is one of the most painful conditions.
Yeah.
That's right in the jaw, coming from the trigeminal nerve?
Yeah, there's yes, it goes into your face. It comes right out of your skull, and there's three branches of the nerve, and there's a lot of reasons that it can cause pain. But yeah, it's patients that have it really are uncomfortable. And then it takes time to figure out why it's happening, right? Is it something that's rubbing on the nerve? Is it an artery that's rubbing on the nerve? Sometimes we don't know why it happened at all. So it's a tough one. And just like any other, when you get to the basics of it, it's the same thing. It's like, let's try the medication. That doesn't work. And during that time, we're trying to figure out why it's happening. And then the next thing would be like a steroid shot at the nerve to kind of calm it down. And then with trigeminal neuralgia, then like the last resort is a gamma knife ablation where they kind of cut the nerve, hoping that the good thing about the trigeminal nerve is sensory. It doesn't do anything else. So if you cut it...
I was going to ask you, for cutting the nerve, are you losing function to your face?
Good point, yeah. So that one, luckily, you can cut. It's just sensory. But like people who have sciatica, they go, can't you just cut that or ablate that? And you go, you can't, because that one's really important. It gives you strength to your legs. So yeah, the trigeminal, thankfully it's sensory, but yeah, a lot of patients go, I have that, shooting pain down my leg. Can't we just cut it or get rid of it? And we're like, no, I'm sorry.
I think a lot of people have sciatic pain.
Yeah.
Coming from, and I guess it starts like in your buttocks and then it kind of wraps around your hip and down the front of your thigh, or it goes down the back of your leg.
Yeah. So we call sciatica, it's like a layman's term for any pain that shoots down the leg. But true sciatica is that nerve that you're talking about. It comes in your gluteal region, goes down the back of your leg. But there's more reasons to have pain shooting down your leg, which is like discs. So radiculopathy is the real most common reason where a disc is pinching a nerve and going down your leg. But we call all of it sciatica, So I know the terms are difficult to define, but when someone comes in, they say, I have sciatica, we kind of know it's going to be one of two things, And
you got to just go get proper treatment.
Yeah,
and give it time, right? Time, rest, healing.
Yeah, even those big things can get better. We say 80% of patients can get better with conservative care. So just, time, anti-inflammatories, rest, avoiding things that offend you. A lot of times those things come and go and they go away.
And I think physical therapy and stretching is a great modality to use, right? Even if they're working with you, it's something you don't always want to be sedentary.
Oh, no.
Right? Because even if you're in pain and people want to rest, at some point you have to have motion.
Yes.
Right? Or it just gets worse.
Yeah, I think there was even a study, they said the strength of your lower extremities equals like your life expectancy. So the stronger you are, the better your balance is going to be, the better your outcomes are going to be. So you want to keep moving. And sometimes it's a catch-22, like if you're in pain, you don't want to move. So then if you don't move, then you lose the muscle mass. And it's like a...
It's a catch-22 and what you want to do.
Yeah.
And within your practice, you've got spine physicians, you've got orthopedists, you've got interventional pain.
Yes.
So if someone calls the office presenting with,
yeah.
they can just call and ask for or explain what's going on, and they'll be sent to the appropriate physician.
Yeah, thankfully at FSA, we have both spine surgeons and interventional pain doctors, but we all know and like each other. so if someone comes to a surgeon and the surgeon's like, okay, they shouldn't have surgery yet, let's try a couple things. They'll talk to the interventional pain guy and go, hey, this guy, probably could use a couple of these things and let's see how they do. So we all talk to each other and we communicate, and I think that's a huge positive of what we do. Or if I had a patient and I go, okay, well, we've done these two things, I think it's time for spine surgery, I have no reservations about talking to the surgeon and having them see the patient and having them fix the problem.
I've got about a minute left. Yeah. Tell me how many offices and where they're located.
Oh yeah, there's a bunch. So the biggest office is Boca, at Boca Regional and Glades. And then I'm at an offshoot at West Palm Beach, so it's by JFK North. There's a Wellington office, a Boynton Beach office, a Fort Lauderdale office. So like South Florida, we haven't gone to Miami or anything like that, but that whole area, there's somebody for somebody,
There's an office near you should you need it.
If you needed it, yeah.
Dr. Cohn, thank you so much.
Thank you.
Such a pleasure to have you. For more information, you can reach Dr. Cohn at 561-269-8646 or info@floridaspineassociates.com. And for All County Healthcare, you can find them at 954-717-7027 or info@allcountyhealthcare.com. It has been such a pleasure. Thank you, Dr. Sue Cohn.
This was fun. Thank you.
My pleasure. And we will see you next week. Have a great Thursday evening, everyone. Bye-bye.